So just let us know where you're joining us from, which part of the country you're in, and which exam you're preparing for, and what deanery you're part of as well. And we'll give you a shout out. I can now see that we're streaming live to the iMedics YouTube channel. So if you're joining us on the YouTube channel, there's a chat box in the right-hand corner. We'll keep an eye on that if you want to type in any questions that you may have as the presentations go on. So lots of people from different parts of the world, actually. It's interesting. So we've got Mohammed Alam, who's from Leicester. Which exam are you preparing for, Mohammed? Mag Salim from Egypt, so joining us. I know that there's lots of international GP candidates as well, studying MRC GP-based exams. So do let us know where exactly you guys are. Today's topics, we've got a different field. It's abnormal platelet counts, which Dr. Mo is going to be talking about, how you should manage that according to the current NICE guidance. I will be talking about bruising, which again is another kind of different topic to what we normally do, but there's a good slant to it. So we'll have an AKT slant and also, of course, an RCA slant as well. So you're obviously up to kind of scratch with your knowledge and ready to kind of tackle the exam. We can see that a few more people now. So Jeanette is joining us from Telford in Shropshire. We've got Hilal, who's in the Wessex Deanery. Mohammed's applying for, so he's actually attending this webinar for AKT and RCA revision. Hilal is preparing for the AKT exam. Do you let us know, guys, whereabouts you're kind of joining us from, so that we can give you a shout out. Mo, what we'll do is we'll give it another 30 seconds, and then what we could do is obviously make a start. I know people tend to join us throughout the webinar. As I said, there's about 242 signups, but not everybody will join us straight away, and not everybody will join us for the live event as well. So we've got Gagan Sethi, who's joining us from Newport in Wales. Welcome, Gagan. Again, which exam is it that you're preparing for? And obviously we can give you a kind of bit more focused. Here we go, fantastic. So we've got Tanisha from Coventry. Tanisha, myself and Mo are from Coventry. iMedics is based in Coventry. So, you know, we work here, we're practicing GPs, we work in Coventry as well. The office where Dr. Mo is at the moment is in Coventry as well. Good to have someone who's local to us joining us. Jeanette, good question. So Jeanette's asked if there's a discount code for the AKT Big Mock. You'll be pleased to know that there is a discount code valid for the next 48 hours till midnight tomorrow. There is a bank holiday sale, Jeanette. So you'll actually get, you know, the discount code will be given during this webinar. It's a huge discount for the AKT mock if you're preparing for that. Tanisha's preparing for the AKT. Gagan is joining us. Is joining GP training in August. So welcome, Gagan. It's an exciting time when you first start your GP training. Amika is from Carlisle, preparing for the AKT exam. And of course, as someone's typed, well, Mo's typed in there, we'll have the discount code. Mo, it's about 4 minutes past 7. So I'm going to hand over to you to start your first topic. And we'll take it from there.
Hey guys, so welcome, good evening. Just gone past 7 p.m. local UK time. It's amazing weather if you are joining us from the UK. And we're going to be covering two specific topics, the hematology topics, that's abnormal platelet counts and also bruising. So what I'm going to do is going to enlarge the screen for you guys and then we'll get started. Okay, Vika, so you should have a full screen hopefully coming across rather than individual slides. Just a quick thumbs up or a quick yes will be good. So this is the outline for this webinar.
I can see your slides on the side, so it's not, there we go, that's full screen.
So guys, we'll just give you an outline for this teaching webinar so you know what's coming. We'll go through the latest guidelines. These are the latest NICE guidelines for an abnormal platelet count. We'll do a Q&A. We'll talk you through after that the discount codes that you can access for the AKT Big Mock and also for the RCA Advanced Communication Skills course. Dr. Sandu will then go on to bruising, again, the latest NICE guidelines, and then you'll have an opportunity to ask questions. Where possible, we're going to try and summarize as much information as we can. and the information that's going to be most relevant for you in an AKT style situation, or if you're sitting, for example, the MSRA exam, and also if it's an RCA video that you're recording to submit to the Royal College. So this is a quick show of hands. Can you raise your hand? So in Zoom, a couple of housekeeping rules. If it's a general chat message, there's a chat box you can click on and enter your chat message. If it's a question that you have, then what you want to do is click on the Q&A icon, and that can be located within Zoom itself. Having said that, if you guys want to just very quickly raise your hands if you're going to be sitting the AKT exam in the next 6 months or so. Just raise your hands if you're sitting the AKT exam in the next 6 months or so. So we've got 4, 5. Won't shout out names, but just want a rough idea of how many people are sitting what exam. 6. So 6 hands have gone up. Okay, great. And then in the next 1 to 2 months, how many people are going to sit the RCA exam? Quick show of hands if you're sitting the RCA exam in the next 1 to 2 months. So we've got three hands going up. Okay, so a couple of people sitting the RCA. And then finally, if you can quickly raise your hands if you're going to be sitting the MSRA exam in the next couple of months, or the next 6 months or so. So a couple of hands have gone up again, so 3. Okay, 3 hands. Okay, great. So let's get started. Like I said, we're going to try and keep this as condensed and summarized as possible. But let's start off with a recap to begin with. So it's always important to start off with a recap so everybody knows what the baseline knowledge is that you require to actually be sitting an exam like the AKT, MSRA, or the RCA. So what's a normal platelet count? Now, all of you should know this is between 150 to 450 times 10 to the power 9 liters. And the other key parameters that you need to be aware of is what is thrombocytosis and what is thrombocytopenia in terms of the specific thresholds. So thrombocytosis is when you get too many platelets and it's a count above 450. With thrombocytopenia, it's all relative. We measure this as per the volume of blood. So per liter of blood, that's how much you would expect in an average adult. Now, the next slide, or the next 2 slides, again, is going to be a recap before we come on to the bulk of the information that you'd need to know for the exams. What are the causes of an abnormal platelet count? So let's start off with thrombocytosis first. So an elevated platelet count. It's quite nice the way NICE have summarized this. They've broken it down into 2 areas: primary and secondary thrombocytosis. And essentially, the key difference between the 2 is that in primary thrombocytosis, you've got uncontrolled production of platelets. And most of the time, or nearly in every case, is related to a bone marrow stem cell disorder. So a good example can be chronic myeloid leukemia. Another example can be polycythemic rubra vera. But then also you have secondary causes. So secondary causes are very different because you tend to get an inflammatory stimulus. So what happens pathophysiologically is that you get this stimulus and that causes an increase in production of the platelets. And there's a couple of reasons. The most common reason for a secondary thrombocytosis is usually iron deficiency. But other important causes that you need to be aware of are cancer, surgery. So for example, someone's had a total knee replacement, steroids, which is of course a type of medication, and infection. And that could be, for example, sepsis, this could be a pneumonia, and it could be a wide range of different infections that somebody may be clinically diagnosed with. So that's the first thing to be aware of, is whilst there's a breakdown within the amounts of platelets that you can subcategorize the condition into, which is thrombocytosis and thrombocytopenia, thrombocytosis is broken down further into primary and secondary causes. In terms of thrombocytopenia, you want to be thinking of 3 core reasons why somebody's platelets may drop. And then there's 3 additional reasons why somebody's platelets may drop. So the 3 core reasons are, this is a way of kind of compartmentalizing data: reduced platelet production, increased platelet destruction, or increased separation. And I'll go through those one by one. So when you have reduced platelet production, that can be for a number of different reasons, the most common ones being nutritional deficiencies and malignancy. When you have increased platelet destruction, you want to be thinking, for example, drug-related causes or disseminated intravascular coagulation, for example. And then when you have increased platelet sequestration, so this, for those of you who've forgotten what this term means or need to have a quick refresh, is basically when a certain organ in the body, like the spleen, holds on to blood longer than it should. And effectively, that takes that blood supply out of the circulation. And because of that, you get a drop in the platelet counts. And this is usually as a result of splenomegaly. And splenomegaly is often caused by, for example, portal hypertension, which could usually be as a result of cirrhosis, liver cirrhosis, for example. So those are three key important reasons that can cause thrombocytopenia and the subcategorization for those. Now, there are three additional reasons that you should be aware of, because when you're assessing a patient who's coming to clinic, let's say it's an RCA type scenario where you are recording a video and you have a patient with thrombocytopenia, in your mind, you want to be going through various different differentials. And the questions that you'll be asking in the history will be, of course, related to those differentials. So the other three causes which are worth mentioning is pseudo thrombocytopenia. What does that mean? Basically, when the blood test, their full blood count goes to the hospital, you can sometimes get a chemical causing, or chemicals within the actual lab, causing a issue with the actual full blood count sample itself, which results in a thrombocytopenia which appears on the blood test itself. But actually, that's not a true thrombocytopenia, because there's been an interference with the blood supply with the actual chemical that the labs use themselves. So that's called a pseudo thrombocytopenia. The other important cause, which obviously we've mentioned in reduced platelet count related to malignancy, is a cancer-related thrombocytopenia. And I'll come on to that very soon. Now, that's super important because on abnormal platelet count. So when you come across an abnormal platelet count, you always want to be thinking about a malignancy. And the reason for that is because if a patient has, for example, weight loss, dysphagia, and they have a thrombocytopenia, it increases the risk of them having a malignancy. In this case, for example, a stomach cancer or a gastric cancer in the example I gave you. And then, of course, you can get something called a dilutional thrombocytopenia. Effectively, all that means is somebody's drank too much fluid, that's diluted the blood, and that's more of a relative thrombocytopenia as opposed to an absolute thrombocytopenia. So I'll come on to a recap in a short while once more, in case we went through that information too quickly. Now, I did say I was going to talk a bit about how abnormal platelets are related to cancer. So there are a couple of 4 or 5, maybe 6 different cancers that you want to be thinking about if you have red flag symptoms in the history, but also a thrombocytosis, so an increased platelet count. And those cancers are lung cancer, endometrial cancer, gastric cancer, esophageal cancer, colorectal cancer, and hematological cancers like leukemias and lymphomas. So if you've got a scenario, whether it's the AKT, MSRA, or the RCA exam, where you have a patient with red flags and they have an abnormal platelet count, you want to be thinking, is this related to a potential cancer? And these are the most common cancers that often present with thrombocytosis. Now, this is all good. I mean, you've got obviously a background to thrombocytosis and thrombocytopenia. You know the parameters, you know the classifications and the common causes. How do you actually manage a thrombocytosis or thrombocytopenia, which comes into clinic, or perhaps even an AKT question? So let's go into that in a little bit more detail. So what we'll do is we'll start off with the thrombocytosis first, and then we'll move on to thrombocytopenia. So a lot of you, when you get a abnormal platelet count, you will become a little bit anxious because you're not quite sure what to do. Is it an urgent referral? Is it a routine referral? Do you need advice and guidance from hematology? Do you need to repeat the full blood count? What do you do? And what I've done for you here is I've summarized, in essence, your management plan and how you should go ahead and treat that patient. So if you have a thrombocytosis, so an elevated platelet count, and you suspect or you have red flags in the patient which may point towards a possible cancer, there's no questions about it. You do a 2-week wait referral. Good example would be a gastric cancer. So you have, for example, weight loss, upper abdominal mass, raised platelet count. It's a 2-week wait. And of course, you would appreciate that some of those are already red flags and you would naturally refer as a 2-week wait, but the case for that becomes a lot more stronger with thrombocytosis. Then you have the urgent referrals. So these are referrals that you would refer urgently. Usually they're seen within 2 weeks, but sometimes 3, possibly 4 weeks, depending on the area and the volume of cases they get. And again, these are relatively straightforward to manage because you're making an urgent referral from primary care into secondary care. Or if you're in a hospital setting, of course, you get a secondary care opinion from a hematologist. But the cutoff for this is if you have a platelet count over 1,000, it's an urgent referral. No questions asked. Doesn't matter if they have symptoms or they don't have symptoms, it's an urgent referral. When you have a platelet count of between 600 to 100, and you have associated clinical signs, a good example being splenomegaly, then again, that will be an urgent referral. And the NICE guidelines are very, very clear about this. Now, for some GP trainees or some doctors who are obviously going through the MSRA exam, the area around platelet counts being below 600 or below, but being above about 400 becomes a little bit murky because you're not quite sure what to do when you get a platelet count, let's say of 450 or 460 or 480. And again, NICE have been quite nice in allowing the guidelines to be very, very specific for those platelet counts, which are around the mark that I mentioned. If you have a persistent and unexplained platelet count of over 450, and you're usually talking about between 450 to 600, then what you can do is you can refer to hematology. It can be a routine referral, and of course, they would do further investigations. Now, this is assuming the patient doesn't have an infection. You know that you've done a, for example, a full blood count using these LFTs and a ferritin, and they're not anemic, for example. And you've taken your history, and you still haven't been able to find out what the reason is for a raised platelet count, and it's persistent. And what we mean by persistent, if it's ongoing for more than 4 to 6 weeks. So you repeat the platelet count 4 to 6 weeks later, and it comes back again elevated. Again, we're looking at our range of about 450 to 600. Then you would routinely refer to hematology. You have this middle ground. So I'm going to talk a bit about the middle ground, where let's say you've got a patient, you know, they're feeling tired. It's a non-specific symptom. You've requested a full blood count and using these LFTs, and their platelet count has come back slightly high at, let's say, 480. A lot of GP trainees or registrars struggle when that happens because they're not quite sure what to do. Assuming there's no red flags, assuming there's no symptoms in that patient, what you should generally do is repeat the full blood count in approximately 4 to 6 weeks. In the majority of people, the platelet count will come back down to normal. There might be, for example, a reason for it. Perhaps, again, it may be a reason that you're aware of, like they've started a new drug, they've had recent operation, maybe they recently had an upper respiratory tract infection. But assuming that everything goes well and they are feeling fine, and the platelet count drops back to normal, then you don't need to refer. But if the platelet count remains elevated, and in this case, if you've repeated it, it becomes a persistently elevated platelet count, and it's above 450, then you would routinely refer onto hematology. So the NICE guidelines, as I said, are very, very clear for thrombocytosis. Now, it's worth doing the reading around the NICE guidelines because there are some sub-algorithmic scenarios that they give you. For example, platelet count of 460 and a patient has mild symptoms or some symptoms or something, what do you do then? And at times it may be a case where you need to get advice and guidance from hematology. So what I'm going to do now is I'm going to move on to thrombocytopenia and how you would manage that in a primary care type setting. And then we'll do a quick refresh, go through all the slides just to very briefly summarize before we take questions. So again, it's very, very clear, a low platelet count with red flags. So again, it could be upper abdominal mass, it could be dysphagia, low platelet counts, it's a 2-week wait. There's no questions asked. Then you have those patients who are immediate referrals. So immediate referrals effectively mean you're sending in the patient same day to hematology. And this will be a scenario where the patient's got a thrombocytopenia and is actively bleeding. So for example, they've got an ongoing nosebleed as an example, or ongoing, let's say, PR bleeding. And then for those patients who have a platelet count of less than 20. So for those patients who have a platelet count less than 20, you are immediately referring to the hematology team because that urgently needs to be investigated. Then you have the urgent referral. So again, the urgent referrals can vary anywhere from a couple of days up to a couple of weeks. Not quite a 2-week wait referral, so they don't go down the 2-week wait pathway, but they are urgent referrals, i.e. need to be seen as soon as possible by the hematology teams. And this is when the platelet count is less than 50, but above 20. So don't forget your immediate referral thresholds. So more than 20, but less than 50, you would urgently refer to the hematology team. Or if the platelet count is between 50 to 100 and they have clinical signs, and again, clinical signs could be splenomegaly, it could be bruising, for example, any clinical signs that may warrant a referral to hematology that may be hematologically related, you will be referring urgently for those patients. And then you have this middle ground again, where a lot of GP registrars and GPs do struggle, where they get a platelet count which is slightly lower than the cutoffs for normal, but the patient seems well, and they're not quite sure what to do. So the NICE guidelines again are very, very clear, which is if the platelet count is less than 100, but it's persistent and unexplained, so you're looking at basically between 50 to 100, persistent but unexplained, then you can do a routine referral to hematology. So you found no obvious cause. But NICE have some very clear guidelines on how quickly you should be doing the bloods. So let's say a patient comes in with a platelet count of 125, and they're otherwise well, they've got no symptoms. You can repeat the full blood count in 4 to 6 weeks. But the same does not apply if the platelet count is between 50 to 100 and the patient's got no symptoms or no obvious underlying cause. In a situation like that, you need to repeat the full blood count within 1 to 2 weeks. And it makes sense, logically it makes sense. The lower the platelet count, the quicker the repeat should be done for the bloods. The slightly higher the platelet count, the longer you've got for the repeat to be done. And of course, this makes sense because if for whatever reason, let's go back to our causes to demonstrate why this makes sense. So if you have, let's say, a thrombocytopenia, which is related to, let's say, a nutritional deficiency or a drug-induced thrombocytopenia, or possibly even a dilutional, you can check for it a few weeks later to see if it's corrected. But also you've got time on your side because you know there's no red flags. You know the platelets are in a relatively safe range, 100 to 150, and therefore you've got that relative luxury of time. Whereas with a platelet count of 50 to 100 with no obvious symptoms, no red flags, you'd really need to be repeating the platelets within 1 to 2 weeks, i.e. 7 to 14 days. So what I'm going to do for you guys now is I'm going to do a very quick brief recap for those of you who've slightly joined us late. And then what we'll do is we'll go through a couple of promotions for the AKT Big Mock and the RCA Advanced Communication Skills course. And then we will take those questions and answer them, hopefully. So a very brief summary: normal platelet counts between 150 to 450. A thrombocytosis is a platelet count over 450, and the thrombocytopenia is less than 150. That should be relatively easy to memorize, but you've always got the reference ranges to hand whenever you get a blood test result back for a full blood count. There are 2 types of thrombocytosis you can get: primary and secondary. Primary is usually related to a bone marrow stem cell disorder. Secondary is usually related to an inflammatory stimulus. In terms of thrombocytopenia, you have 3 core pathophysiological causes: reduced platelet production, increased platelet destruction, and increased platelet sequestration. Sequestration is basically when the spleen holds onto blood, and that results in a loss of platelets in the circulating blood, which results in an overall relative loss in the platelets, which results in obviously thrombocytopenia. And then we touched on some of the other causes which we've listed below. We gave some common some common reasons why a thrombocytosis may be linked to certain cancers, and we listed those relative cancers in terms of how common they are to thrombocytosis, and those were lung, endometrial, gastric, esophageal, colorectal, and hematological. You can see from that list that 1, 2, 3 are GI cancers. That's gastric, esophageal, and colorectal. So certainly if you look at the 2-week wait guidelines for upper GI cancer referrals, you'll see that platelet counts, thrombocytosis is mentioned in those guidelines. That's an easy way to remember the NICE guidelines for upper GI 2-week wait referrals. Then we covered the management plans for thrombocytosis. We covered when you would refer for a 2-week wait, when you would refer urgently, when would you refer routinely, and when would you repeat a unexplained thrombocytosis where the thrombocytosis is between 450 to 600. And then we covered thrombocytopenia management. Again, when you would refer for a 2-week wait, when would you refer immediately? So that's basically same day admission to the hospital. When would you urgently refer to the hematology team? And when would you refer as a routine referral? Again, giving you the thresholds on when you can repeat the full blood counts. So guys, what we're going to do, we're just going to bounce out of the share screen for a moment to allow you to ask questions. So if you've got any questions, what you can do is click on the Q&A icon, and then you can type in the question for your for the specific topic area that you want to ask about. And what I'm going to do is just bounce onto our website for a moment and show you a couple of promotional discounts we have on for the bank holiday. Okay, so we've got a bank holiday 25% flash sale on. What you do need for that is you do need a discount code. So if I go to GP exams, so it's the mega menu at the top. If I open up AKT exam and the RCA Advanced Communication Skills course. So for this, we've got an upcoming AKT Big Mock in October and January. If you click on this on the date that you'd like to select, so at the moment it's $99.99, I'm going to add to cart, and then this will take me to the checkout page. If I just remove the other product that I added, and then if you enter your coupon code here underneath, apply the coupon code, and it will take off 25%. So in this case, it'll take off £25 off the AKT Big Mock. Don't forget, guys, that this coupon code expires in about 48 hours time. Well, under 48 hours, about 36 hours time. There are some other products you need to be aware of. So for those of you sitting your RCA Advanced Communication Skills, RCA course, your RCA videos are being submitted very, very soon. We have an upcoming RCA Advanced Communication Skills course on the 13th of June. It's a full day course. We do some live mocks that you can participate in. So we give you feedback there and then on those live mocks that you do with us. But we basically take you to advanced communication skills that the examiners are looking for, which allow you to score the highest marks. So these are different scenarios, result scenarios, counseling scenarios, for example, angry patients, ethical scenarios. The types of scenarios are women's health, for example, that you'd be looking to submit on the day for an RCA video. And again, there's a 25% discount on this. So if you add to cart, put in the code, which Dr. Sandhu will type into the chat box, 2021, it'll knock off 25% off the price. And the course program looks like this. So we cover 5 high yield communication skills areas. And we do a live demo at the end of each of those. Altogether, I think we cover 10 core topics for advanced communication skills. Highly, highly recommended. We also go through telephone stations, result stations, 2-week waits, and chronic disease. And it's probably one of the most intense courses you go to in terms of the amount of knowledge that you learn, but also the perspective that the RCA examiners have when they start marking the videos that you submit. And of course, myself and Dr. Sandhu will be there. The other couple of things that are worth mentioning is for the AKT exam, let's see if I can bring it up, and also for the MSRA exam, for those of you sitting the MSRA exam, we've got a free question bank. So we've got 3,000 free questions for the AKT exam. Those include stats and health administration. You need to choose the package AKT free, choose how many months you want it for, add to cart, or free access now. For those of you who need intense revision, want extra material that's going to really boost your score, we've got the gold package. That's got an extra 750 bonus MCQ video questions. It's got 750 podcasts, and also you get 750 mini teaching videos, as well as free flashcards sent out for revision to your home address. It's a don't pass, don't pay promotion, the AKT Gold package, and you can choose between 1 to 12 months. And the same applies for the MSRA exam. You've got an MSRA free question bank with SATs, and also an MSRA Gold package, which is, again, don't pass, don't pay. And then the very last thing that's worth mentioning, well, 2 things. If you're sitting the RCA exam, we've got an online RCA video course. It's don't pass, don't pay. It basically takes you through all the nuts and bolts and the theory you need for the RCA exam. But then if you want to actually watch high yield RCA recorded videos to see what you need to submit to score the top marks, we have our gold standard RCA consultation videos. Basically, it's myself consulting with real actors who would have appeared in role-playing scenarios with the RCGP. We provide in-video breakdown of what needs to be done to score the highest marks for communication skills, for data gathering, for management, and we break it down second by second. So you can read and see every second what the doctor's doing in order to score the top marks. And by seeing that and learning that, you can actually boost your scores in all 3 domains. Again, we've got different packages, so you can choose what package depending on your budget: the bronze package, the silver package, and the gold package. And again, don't forget, guys, 25% off if you buy in the next 36 hours. And that is only for this bank holiday Easter. And then the last thing to mention, guys, which I'll talk about a bit later, is if you enjoyed the free teaching webinars today, if you enjoyed our free AKT question bank, which we've spent about 3 years designing, if you wouldn't mind leaving us perhaps a nice Google review, and I'll put the link into the chat box very, very soon. So I'm just going to stop the screen share there for a second whilst we get the questions up. So anonymous, okay, so that's probably not appropriate for this webinar. So I'm not going to answer that today. For thrombocytosis, so whoever asked the A-level question, you're probably in the wrong webinar for that. If you send us an email at info@i-medics.co.uk, we will get that answered for you. We can highlight some relevant books. For thrombocytosis, I guess the mnemonic LEGOC should help in remembering the cancer causes. Abdul Wahab, there are lots of different mnemonics. And certainly if LEGOC or LEGOC helps you, then of course you can use that to memorize the cancer causes. If you can type out what LEGOC stands for, that will be a great use, I'm sure, to all the other participants and attendees today, because obviously there's different mnemonics for different learning points, but LEGOC is a good one if it includes all the relevant cancer diagnosis that you might need to know for thrombocytosis. Okay, guys, I think that's all the questions from everybody. So what we'll do is we'll allow, yes, Toyin, there is a discount for the MSRA gold package. It's 25.21. If it's not been activated, I'll do it now for you. But I'm going to hand over to Dr. Sandhu, who'll basically start talking about bruising as the next teaching topic.
Perfect. Thank you very much, Mo. So, yeah, welcome, guys, obviously to the second stage of this AKT RCA revision webinar. Remember, different slant today, a bit of a hematology blood test investigation type slant. So we're going to talk about bruising, and NICE CKS has a specific topic on this, so it's important that we're aware of this, whether you're preparing for the MSRA, obviously your GP entry exam, or the AKT exam, or of course the RCA exam. So as with a lot of my webinars, I'm sure you're very familiar now with the structure that I tend to use. We'll define what we mean by the term bruising, and we'll talk about some of the key causes, how we investigate, and how we manage the different presentations. So what is a bruise? Well, NICE basically defines it as a hematoma, and that's, you know, a collection of blood that will collect underneath the skin, which is caused by vascular damage or injury. But if you're doing the RCA, you just keep it nice and simple. It's a, you know, you've had some kind of injury and there's a collection of blood that's formed in the arm or in the knee or wherever it may be. Does that make sense so far, Mrs. Smith? So just keep it nice and simple. You don't have to go into medicalizing it, but that's more of a medical definition. Of course, you want to score well for your RCA, so you don't want to be going into too much medicalization. How do we define what can cause bruising? Now, there can be a number of different ways to think about what causes bruising, and we need to be thinking about this when we're doing our history from an RCA perspective. And if you're preparing for the AKT, then you want to know about different causes. And so we've broken them down into different segments. So the first segment is trauma, and that's an obvious thing, right? So you, me, we could all be playing some sport. You know, somebody tackles you late, or you get hit by a tennis ball or a cricket ball, you may end up with a bruise. You've got non-accidental injury. That's a red flag. That's the pediatric red flag, when you've got a child who's come in with a bruise in an awkward place, or perhaps their parents tell you a story about, say, a 4-month-old who was running up the stairs and fell down a few stairs, and that's how, you know, my little girl got this bruise. You have to put it into context and think, can a 4-month-old girl run up and down the stairs? That should be triggering off the alarm bell in your head. You've got domestic violence. So sometimes you may have a patient who's indrawn, who perhaps just needs a little bit of probing before they eventually admit to you that actually this was done by my partner, but I don't want my partner to get into trouble, doctor, you know, and what's going to happen next, doctor? So be mindful when you see certain patients who present with bruising that domestic violence could be a cause. Falls, so falls happen at any age, but of course we tend to see it in our older population. You have someone who's elderly, who lives alone, who may have tripped and they sustain various injury which leads to a bruise, and so that's something to be mindful of. Then you've got the vascular causes, so some very interesting causes. So senile purpura. So when I was an FY1, I was based in dermatology, which was a really good job. It was dermatology and acute medicine, but most of the time was spent in derm with the on-calls on acute medicine. So you got a nice fix of medicine and dermatology. And senile purpura was an interesting finding because actually we'd often get called to review patients on the ward who'd be elderly and they've got a purpley rash. And actually the senior dermatologists, once I, to shadow them and eventually I became comfortable myself, they'd go and review the patient. Patient's been on hydrocortisone, then they've been switched to Dermavate. Still there, doctor. Why is the skin purple? Is it lichen planus, lichen sclerosis and lichen planus rather? The dermatologist would go, no, this is senile purpura. So if you look at the skin of the elderly patient, what's happened is the collagen production is now impaired. The skin's quite lax, it's become weak, and the capillaries are quite weak, and therefore they burst, and you get this bruising that forms in an otherwise well elderly patient. You've got simple purpura. So this is something where people might say to you, oh, doctor, I bruise easily. So both myself and Dr. Mo are still practicing as GPs, and we still enjoy the patient contact, and it's not abnormal. In fact, I spoke to somebody only a couple of weeks ago, and she said as well, oh, doctor, actually, I do bruise quite easily. I've got a bruise on my arm, I've got a bruise here. And so what you normally have here is there's no underlying cause. It's normally in women, and they're often very young, like 20s and 30s, with no other medical history or no drug history of note. Then you've got hereditary hemorrhagic telangiectasia, and that's a genetic condition. So it's an autosomal dominant condition. And you can get these kind of tiny blood vessels. So telangiectasia is often when people talk about basal cell carcinomas, they talk about a characteristic features that's got like telangiectasia, little blood vessels that you can see on the dermatoscope. And in HHT, you tend to get these thin blood vessels near parts of the skin, mucous membranes, and some organs as well that can lead to bruising. So obviously when you're taking a history, you want to find out if there's a family history of any similar problems. And in something like HHT, you'll often find that, someone else in the family, and there's an extensive family tree where this kind of similar problem has been occurring. Continuing with vascular, you've got three other causes to be mindful of. So one is Ehlers-Danlos syndrome. And that's, of course, now a bit of revision for you, but you've got those patients who've got hypermobile joints, right? The knee fully extends, the elbow goes beyond. I don't have hypermobile joints, guys. I'm just, but it literally goes all the way beyond where it should go. The skin is very loose and very extensible. And these patients can have like bleeding in the gums. They can have lots of bleeding after they've had any type of surgical procedure. And in females, they get heavy periods. You've got osteogenesis imperfecta. This is a classic AKT type question. So if you look at here, we've put blue sclera, short stature, and kind of fragile bones. That's a kind of triad that's often mentioned in the AKT stem. So now when you think about that, the cog wheel should be going, oh, blue sclera, quite short patient, thin bones, kind of weak dental, lots of weakness in their teeth, and also hearing loss. Diagnosis equals, what is the most likely diagnosis? Select one option, osteogenesis imperfecta. And of course, it's something to be mindful of. Vitamin C deficiency, it's not something we see that often anymore, but some of you will probably remember from medical school days, you call it scurvy. It's something that you learn in your physiology modules. Now, obviously, lots of us have, lots, especially in the West, lots of fruit, oranges and so forth. So you tend not to be deficient in vitamin C. But if you are someone, or you have a patient who's got a very bad diet, or perhaps they are from a lower socioeconomic background, or they're homeless, where they're not, exposed to a good diet, they don't have fresh fruit, fresh vegetables, and if that's sustained over a period of weeks and then months, that can lead to vitamin C deficiency. That can lead to kind of bleeding and bruising and wounds that tend to heal very slowly. So it's important to be mindful of this. Then you've got platelet disorders. So Dr. Mo's touched on sort of abnormal platelets in his earlier webinar presentation. And this is a slightly different slant. So when we see patients with a bruise, what kind of platelet problems could be responsible for this? You've got ITP, which is of Idiopathic Thrombocytopenic Purpura, and that's often seen in children, and normally they'll have a recent infection. So mum and dad will tell you that, he's had a cold, he's had a fever, he's had a runny nose, sore throat, and now he's come out in this kind of purpley rash, and that's because that virus often results in these antibodies that are produced, and they start to attack the platelets, and so you get lots of bruising. You get those little petechiae, so there's tiny pinpoint purple little spots that appear on the body, nosebleeds, and of course, in female patients, heavy periods as well. The patients are normally otherwise well, and you can, very rarely, you can find that the spleen is enlarged on examination, but this condition normally gets better. So it's a self-limiting disease, and about 90% of children will be completely better within 6 months. But some people do develop chronic disease where they have these symptoms, but they're otherwise well. HSP, so Henoch-Schönlein Purpura. So again, you may remember if you've done a pediatric rotation, it's a vasculitis, an inflammation of the vessels that affects different parts of the body, like your skin, your joints, your bowels, the kidneys. And again, there's often a kind of a recent upper respiratory tract infection, like a runny nose, sore throat, fevers, cough, and so forth. And so patients can present with different symptoms like abdominal pain, hematuria, because remember we talked about different areas, joint pain, hemarthrosis. And again, these children are often seen in CED. They may have a blood test done to rule out other causes before they're diagnosed with HSP. And often, it's just a case of watchful waiting, and most people will get better within a few weeks. Other platelet disorders to be mindful of, so cancers, this is what we worry about mainly. So you've got your acute lymphocytic or lymphoblastic leukemias or acute myeloid leukemias, and these can present with a number of different diseases. So remember, you want to be asking about this. So I've done a hematology job as a GP trainee. It was a fantastic job, and it gave me an opportunity to learn more about different pathology and how it affects patients from a hematology perspective. One of the key things is such a vague thing, and you all see this day to day, which is, doctor, I feel tired all the time. 99% of the time, the tired all the time patients don't have any serious pathology underlying, but you'll get a small percentage who will have something serious underlying. So if they've got bruising and they're talking about fatigue, they've had lots of recent infections, they get bleeding all the time, you want to be thinking about doing that blood count to see if there's an underlying, pancytopenia, and they'll have all the cell counts fallen, like the white cells, the neutrophils, and the HB, because if that's the case, that's an urgent referral. Well, it's normally picked up by the lab, and they'll have already got it to the hematologist, who will have done a blood film to see if there's like blast cells and things on there. You can get a condition called a neuroblastoma. This is pediatric revision. It's basically where you've got a kind of mass in the abdomen, but lots of bruising, and the classic sieve. So that the sieve in the question is a child who's got lots of bruising. On examination, you feel that there's a big mass in the abdomen. What's the most likely diagnosis? Neuroblastoma. So you've attended the webinar. You'll now know that you can put that that kind of process together in your mind and put those two together and be like, all right, that's the most likely diagnosis. Myelomas. So you'll know that with myeloma, you get other things like hypercalcemia. There's a mnemonic for this, by the way. Someone mentioned the mnemonic earlier. There's the one I use is CRAB. C for calcemia, hypercalcemia, R for renal failure, A for anemia, B for bone pain. If you get bruising with it, start thinking about myeloma, especially in the older population. You can get aplastic anemias, which is where the bone marrow is affected. And again, it's very similar to the ALLs and the AMLs, where you've got someone who's got lots of fatigue, very drained, exhausted, lots of recurrent infections, lots of bleeding. Again, this warrants an urgent blood test, and you'll often find that there's a falling cell count. You can get it in end-stage patients with chronic kidney disease. So you may see patients who are on dialysis with a very low EGFR, who are really struggling. And these patients may present with bruising. Liver disease is another one. And again, there's issues with the clotting factors and proteins because of the liver's impaired function. And that can lead us to having like patients with recurrent bruises. Of course, there'll be other features of liver disease like gynecomastia, spider nevi, jaundice, hepatosplenomegaly. There may be a history of alcohol or drug abuse. So obviously do be mindful of that when you're kind of seeing and reviewing these patients. Then you've got your more specific kind of coagulation disorders. So you'll probably remember haemophilia A and haemophilia B from your time at med school. They're both X-linked conditions. There's about 1 in 5,000 males affected and 1 in 30,000 females affected. And basically, it just depends on which of those clotting factors is affected. And that can then lead to spontaneous bleeding, like, for example, in the knee or the ankle or the elbows, different parts of the joints, and also muscle hematomas. And often these cases are managed in conjunction with advice from a hematologist. Mostly the hematologist will actually know these patients very well, but even if they didn't, you can obviously either make a direct referral or you can get advice and guidance. And then also sometimes the liver's function can be, or the clotting factor synthesis from the liver can be impaired, and that's because the liver's been damaged by things like alcohol. Alcohol abuse is a classic trigger, which can lead to bruising from the coagulation disorders side of things. Then you've got vitamin K deficiency. So again, going a little bit backwards now into kind of medical school territory. These are things that you may have forgotten, but it's very important that, when someone's got vitamin K deficiency, you don't see it as often in Western medicine, but you can see it in people who've got gastro problems, where there's issues with the amount of, important vitamins being absorbed into the body. So things like, celiac disease, or inflammatory bowel problems like Crohn's disease and ulcerative colitis. But in the kind of other parts of the world, you can see it as part of malnutrition. So people are not getting enough nutrients in their diet, and that can lead to vitamin K deficiency, and that then interferes with our clotting factors and impairs the clotting cascade, and therefore we get these kind of easy to bleed and lots of bruises that can form. And it might just be someone who's asymptomatic, or they may get lots of heavy bleeding, whether it's a GI bleed or a severe kind of bleed in the brain. So it's a wide spectrum of vitamin K deficiency. It can present with a wide spectrum of disease. Von Willebrand's disease, this is the commonest inherited coagulation problem. It's an autosomal dominant condition. So you'll see it equally in males and females, and therefore it'll be a positive family history, whether you're answering a question for AKT or you're reviewing a patient. Of course, we always ask about family history, and these are the reasons we ask about it. And often, again, they bleed very easily. And what happens is that you get recurrent nosebleeds, or you get a female with heavy periods, or someone who perhaps bleeds excessively more than they should after some kind of procedure, whether it's a major operation or a minor operation or dental procedure, and so forth. Generally, again, there's a good prognosis with this condition under the guidance of a hematologist. And then obviously you've got amyloidosis, again, very rare condition, and again, managed under specialists, but there can be abnormal proteins within the body that are activated, and they can interfere with our clotting process, and that can lead to the kind of bruising that comes up within the body. And then the other thing, so this is a bit more relevant to us. So in primary care, of course, we do medication reviews, and when patients present to us with bruising, you want to be looking at their medication. So what medication are they on? Is there something there which could be contributing to the bruise? When was it started? How quickly after starting that drug did the bruising start? The classic drug, so think about this now, steroids. How many patients do you see with polymyalgia rheumatica who may be on long-term prednisolone? Corticosteroids, remember, they thin the blood. We know that they thin the blood. They cause the collagen to kind of become weak, and you get atrophy of the skin. That can lead to bruising. So we have to be mindful of this. And of course, if you're thinking of stopping it, you've got to go the risk versus benefit of obviously flaring their symptoms. If in doubt, you can always get advice and guidance from the specialist who started the patient on that drug in the first place. You've got drugs that interfere with platelet function, and the classic 3 or 4 to be mindful of: aspirin, which we see in many of our cardiac patients; your NSAIDs, so ibuprofen, naproxen, your chronic back pains and arthritis type patients; clopidogrel, again, patients who have had ischemic heart disease; and of course the one that we often forget are the selective serotonin reuptake inhibitors. So we see lots of patients with depression. We put lots of patients on sertraline and drugs like that. So do be mindful if the bruising started within a certain amount of time within taking this drug. We need to be mindful of this. We need to know about this and make a decision as to whether we continue or not. Of course, there are other drugs. So we've touched on alcohol already. So alcohol can cause thrombocytopenia. We've touched on the fact that chronic alcohol abuse can actually damage the liver and interfere with our clotting cascade and the proteins that are produced, and that can lead to bruising. There are other drugs to be mindful of. You've got classic antibiotics, nitrofurantoin for UTIs and penicillins. You've got your anti-epileptic drugs like carbamazepine and valproic acid, quinine, which we often give for muscle cramps, propranolol, which we give to our patients with anxiety. And obviously older patients tend to be on thiazide diuretics like benzoflumethiazide. And then, of course, you've got the obvious three, the big hitters, the warfarins, the heparins, and, of course, your NOACs like rivaroxaban, dabigatran, and apixaban. These are the common ones. It's so common for someone with warfarin to have bruising that often patients kind of almost accept that it comes with the drug. Investigation. So what kind of things should we be doing? Well, the NICE guidance says we should be doing a simple test, which is a urine dipstick, to look for any non-visible hematuria, which might then suggest that there's an underlying bleeding problem or kind of a vasculitis. In an adult who's got unexplained bruising, bleeding, or lots of kind of, tiny little pinpoint petechia that come up, or they've got an enlarged spleen/liver, we should do a very urgent full blood count. And what NICE means by that is you need to do that within 48 hours and get a blood film with it. So now, interestingly, hematologists will often already be alerted if, for example, you just put a random blood count in and you weren't expecting to find anything, and actually the hemoglobin, the white cells and the neutrophils are really low. That would automatically often alert the lab anyway to say, oh, who's the hematologist on call? It's Dr. So-and-so, please can you take a look at this? And then that hematologist will look under the microscope specifically for ALLs, AMLs, aplastic anemias in a serious disease. And we should be thinking about doing these blood tests pretty quickly. Obviously, clotting screen, liver function, renal function is sensible as well. In children and younger patients who've got unexplained bleeding, again, we should be offering a blood count within 48 hours and a blood film. Good practice. And again, if you want to be looking for other things as well, a clotting screen is sensible. How or what should we be doing with patients who've got abnormal bruising? So if the person's got significant active bleeding, it goes without saying they're going to go to hospital, right? So an acute GI bleed, for example, someone who's hemodynamically compromised, for example, hypotensive and tachycardic, they need to be in A&E, they need resuscitation, they may need, for example, an endoscopy and so forth. If it's something a bit more stable, so if you're thinking this is a child and they've got a history that doesn't match their development and they've got bruising and I'm worried about a non-accidental injury, this patient needs to be referred. This needs to be discussed with your child protection lead at your practice. They need to be referred immediately to the right service. And the NICE says these can be vary rather. It could be like, for example, the NSPCC, it could be the police, obviously if there's an immediate danger, or it could be discussed immediately with the pediatrician. And there's always a child protection pediatrician on call in each area who you can run that case by. And they'll often say, yeah, send the child to CED, often without examination, so they can actually do the initial assessment. If you don't think there's a non-accidental injury, but you think that the patient may have, features of a leukemia because they've got unexplained bruising, or they've got a large spleen, or their full blood count shows features of leukemia, i.e. the hemoglobin is really low, the white cells are low, the neutrophils are low, the platelets are low, that's an urgent admission to hematology. It goes without saying. And I've seen that happen before when I was a GP trainee. There was young patients in their 20s who were admitted immediately, no questions asked, and within maybe 24 hours, there was already talk about starting chemotherapy. Like, it was that quick. It's not, something that they sit on. They'll do a PET scan. They'll see if the disease has spread anywhere, and straight away, it's like, let's start talking about chemotherapy, pros and cons. So if you see that, if you're sitting at the end of your clinic on a day, or if you're doing an AKT question and you see a fallen cell count like that, you've got to obviously be mindful that this is an urgent admission. If children have periorbital bruising, so like in the eye area, we should get them seen within 48 hours to make sure there's kind of nothing else going on out there, and of course to rule out a neuroblastoma. I told you earlier on that if you've got someone with lots of bruising and with a mass in the abdomen, that's a classic feature of a neuroblastoma. That's an urgent pediatrician referral. Otherwise, children, if they're stable and they've got no other problems, it might just be a case of us speaking to the on-call pediatrician or hematologist, and often they might say to you, is the child well? Is there any concern? If there's not, right, can you arrange a full blood count? And then we can obviously review with the results. Again, the leukemia with adults, it goes without saying, if you've got someone who presents with bruising and they've got some other features, like I mentioned earlier, fatigue, weight loss, night sweats, fevers, recurrent infections, and you find that the white cells, HB, neutrophils and platelets have dropped, it's an urgent admission to hematology. So do be mindful of that. And then there's obviously the classic stuff. This is what we see day to day, really. So simple bruising, I've done the blood count, everything looks fine. There's nothing specific that you then need to do because you've ruled out underlying pathology. If there's pain, obviously you can advise simple like paracetamol. Otherwise, it's just a case of monitoring. People who take warfarin, we obviously need to keep an eye on their INR. We can do a clotting screen. And of course, we can liaise with the coagulation clinic as well, who are very good, as I'm sure many of you will know, who carefully keep an eye on the patient anyway. And if there's a medication, so we mentioned that list, like steroids, that can trigger off a fall in the platelets, then obviously where possible, we should try and stop that drug, or at least do the risk versus benefit. In other words, stopping the steroid, what effect will that have on the patient's symptoms? And obviously after that risk versus benefit analysis, we can then make the decision about whether to continue or not with that drug. So open it up for questions. I'm sure many of you will have seen our social media. We will post the links. And if you're not aware, while the questions are coming up, you can follow us on Instagram, inspire_medic, or iMedics rather, Inspire Medics, and you'll see lots of revision learning cards, a new style, which our team are working on at the moment. We have got a Facebook group for AKT, RCA, and the MSRA, which has, again, revision cards and videos going up. There is the YouTube channel, Inspire Medics, where we do stream our webinars live, and we put teaching videos up on there. And this webinar will be on our YouTube channel. Once the live event has ended, it will fall onto the YouTube channel. We're on Twitter, inspire_medics for latest medical news, LinkedIn as well. And of course, we've got some fantastic Google reviews because of people like yourselves. If you did find it useful, do recommend us to your friends, your deaneries, and of course, leave us a nice review as well. We'll open up the floor to any questions that anyone may have. Okie dokie. Excellent. So you've got a few bits there. So no specific questions. Still lots of people here, which is great to see. Interesting topic, a bit different to what we normally do, but we felt it was very useful for all of you guys really to kind of get exposed to that where possible, and use it for your revision and stuff. What we'll do is we've pasted in our social media handles as well. We've obviously got a sale on as well this weekend, so 25% off. Do use that. Those codes will only be valid till midnight tomorrow. So if you are planning the AKT mark or the RCA course or the videos, and obviously do use that. I'm sure it'll be useful for you. Any questions, guys, or anything you want to tell us before we wrap up? If there's any other topics that you want, do let us know. Reach out to us, because a lot of the teaching that we design, we like to bear you guys in mind before we do that. I don't think any questions have cropped up, which is nice. I'll have a bit of water. Mo, if there's anything you want to add in.
So guys, for the RCA Advanced Communication Skills course, which is coming up, I think, in about a week and a half, you for the first 3 people who use the coupon code, you can actually get £50 off. So the coupon code is 50 RCA, capital letters. So 50 RCA. It's in the chat box if you haven't seen it. So first 3 people, £50 off. That's much larger than the discount code we've got on for the bank holiday. And that's because that advanced communication skills course for the RCA is coming up in about 10 days time. If you do enjoy our products, so the free AKT question banks, the free MSRA question banks, and some of the free videos we have for the RCA, please do let your friends and colleagues know. I mean, we've spent 3 years on those free exam question banks. I think we're the only organization in the UK, if not the world, that has a complete free exam question bank for the AKT and the MSRA. So please do let your friends and colleagues know. If you have any ideas and suggestions, you can always drop us a message at info@i-medics.co.uk. It'll always be picked up by our team. And then for those of you who are sitting, so I'll just do a share screen, show you guys something. For those of you sitting the RCE exam, it's really worth checking out our YouTube channel. So we've got some amazing videos going up. So we've recently hired 2 or 3 video editing guys podcasters, and also graphics designers. And what they do is they create videos on NICE guidelines, but these are videos that are more relevant for patients, but also for doctors, because they explain how you should, basically they go through how you should explain conditions to certain patients to make them easy to understand. So for example, as an example, what is chronic kidney disease? So if I play this video.
Chronic kidney disease. It is the loss of kidney function over months and years. Kidneys.
So this video here is a good way of trying to learn how you would explain what is chronic kidney disease to a patient. It's only 26 seconds long, but super, super valuable, because our team has spent a lot of time trying to take complex conditions that NICE talks about and turn them into easily explainable conditions that you can explain to patients. So again, it's really worth using. Again, diabetes. If you want the whole video, so they're broken down into questions, but if you want the whole video, you can click on something like, do you have diabetes? It's a 60-second video, but it has 5 core questions in it. So stuff like, what are the symptoms of type 2 diabetes? How do you treat type 2 diabetes? And what are the risks, or why you should be worried about type 2 diabetes? Again, these are brand new videos. We seem to be getting a lot more traction on these videos than the previous videos that we've uploaded, which suggests that people are liking them. And then don't forget, guys, on the website itself, I think we've got a brand new section. So if you go to the homepage, we've actually got podcasts which are going live. So if you go down to the bottom, you've got a podcast there. Or if you go to the top in the mega menu, you've got podcasts, a brand new section that's come up on the podcasts on the website. And then you can play and subscribe to our podcast. So you can download them, the download icon here on the right. You can play, so you can click on the play button. And every week or every couple of days, we'll be uploading podcasts that you can listen to. You can listen to these very, very soon on Google Podcasts, on Amazon Audio, and also on iTunes and all the major podcast providers. You can also listen to them on Podbean. So Podbean is it's like a podcast hosting website, and our podcast will be located on those. And if you do, so we only launched this literally 2 or 3 days ago. If that is the case, you can follow us and you can share with friends. And this is our Podbean channel, which you can see. And again, you can download, share, or like. So it's worth exploring that. Keep an eye on that because we'll be uploading regular podcast discussions with healthcare professionals, discussion with leaders in the National Health Service, like clinical directors, discussions with our ambassadors. Me and Dr. Sandhu will be talking about different topics, really interesting topics that you may want to know about. For example, the role of blockchain in healthcare, in patient records, the role of blockchain in finding jobs, really like topics that are related to technology that will bounce into the future. And of course, we'll be doing autobiographical podcasts as well. We talk through other individuals' lives who are doctors who have done really well. So we might get, for example, one of the deputy directors of the National Health Service to come on, and you can hear about their journey through the National Health Service. So I'm just going to stop there because I'm going to hand back over to Dr. Sandhu, who may have some questions.
Yeah, no, fair enough. Yeah, so it's just to wrap up really. So there's no specific question. So do use that, guys. There's one thing I just wanted to say actually. So we've got we're looking for ambassadors from the GP training program. So I've just posted a link into the chat box here. So that's the registration link. It is a webinar. It's in a couple of weeks. I think it's on a Sunday evening. If you're interested in joining a evolving team like iMedics, we've got fantastic ambassadors all over the world. We're looking to get GP trainees on board. And if you're interested, this could be an exciting opportunity for you. You'll gain lots of things from us like mentoring, connections, an opportunity to get involved with iMedics. Some of you may want to get involved with teaching, videos, CV, building exercises, and want some support as you go through. We're very well connected. And so it's an exciting program. And we're going to be talking more about that in the webinar. And that webinar link is there. It will also be, obviously out on emails. You'll see it in your emails in the coming weeks as well. But if you are interested in that, certainly an exciting opportunity. So do look into that. But other than that, nothing else to add really. So hopefully it was useful today. We will wrap up. I know it's a Sunday evening. Still a nice day. So enjoy the rest of your weekend. Obviously, hopefully nice weather tomorrow as well. So enjoy your days off, those of you who are not working. We'll of course be in touch with you guys very soon. So it's a good evening from me, and I'll hopefully see you guys soon. And I'll finish with Dr. Mo with the final words. Yeah, absolutely, guys. So the last couple of things, obviously, we are in the middle of a COVID pandemic. So wherever you are, you yourselves and your families, hope they're all safe. Please do check out the new features on our website. We are actually upgrading the entire website in about 2 months' time. Everything's going to get upgraded. It's got a brand new look and feel to it.
We have obviously opening our batch 4 of Ambassador. After the Ambassador applications, that's worth exploring if you're interested in like building up your CV so to make it look better. And there's lots of perks for the Ambassador program, so do attend that webinar. And then finally, don't forget the bank holiday discounts. There's 25% off most products. 2021 is the discount code, and we'd love to see you in the next teaching webinar. So the next teaching webinar, which will be in a couple of weeks' time. Keep an eye out for the emails. If you're on our email and subscribing list, don't unsubscribe, because sometimes I appreciate you get a lot of emails, but some of them are going to be very, very important because we launch new features, new products, new services. Job opportunities that we may have, private medical work that might be quite lucrative. It's worth always keeping an eye out for those emails, so keep opening them if you can. So enjoy your bank holiday weekend, and we'll hopefully see you soon. And don't forget to mention the free question banks to your friends and to any colleagues that you may know. Okay, guys, take care and bye.